Well, friends, good morning. And I do realize that it is your last day, and I hope in the 2 days that you spent here in this course, it will make your practice, much better. And I would just like to, if you are interested, I offer my services. You can write me a mail. Okay, you can note down. I'm a retired guy, so I have a lot of time on my hands. So if you have any challenges, you can always send me. You have to do me a favor by making a small PowerPoint presentation and send it to me. I'll be very happy to do my best to answer any of the queries that you may have. Now, this morning we are going to be talking about the masquerades, and I'm sure you're all familiar with this. The dictionary meaning of masquerade is deception. Like I pretend to be what I am not. I pretend to be know all, but we all know that we cannot know everything. Okay, so we have all limitations of knowledge. So this is impersonation or creating a facade about something if you don't know. Now, why should we be studying this? Because patients with impersonating information might present to you, and they may have, sometimes fatal disease. So you might be the first person as a ophthalmologist and UVA expert to come across a patient who may have an underlying very serious systemic problem. And they would have, now this is where you have to use your clinical sense. I don't depend too much on the labs. I like to use all my clinical senses, in reaching that kind of conclusion, and only do very limited, very targeted investigations. So these are the patients who will come with unusual presentations, and they would not respond to your, so you have to have very high index of suspicion. Look, this patient is not responding to my treatment. Okay, think back. Why is he not responding? Why is she not responding? Okay, so you need to keep asking those kind of questions. Now, here is a patient. There is an obvious cataract here. The young patient was sent to me by a cataract surgeon. And why would cataract surgeons send a patient to a UVA experts? What's uppermost on their mind? Anyway, typically, cataract patients need to have quiet eyes. Why? Since uveitis, inflammation should be quiet for at least 3 months before they will operate. Okay. So do you agree with what the cataract surgeon felt, that this patient had uveitis? Does he have, or he doesn't have? So the cataract surgeon got carried away by the so-called pigment deposit on the lens, and he thought this patient has, uveitis which needs to be controlled. So you agree that this patient has pigment deposits on the lens? What do you think he has?
Not.
Blood? Blood? Blood, okay. Yeah, who said that? Yeah, patient had history of trauma. Young people coming with unilateral cataract, they will invariably say, well, there is a history of trauma. They will say something, hit them in the eye. So what do you have in mind? Traumatic cataract. Why these deposits?
Even from bad eyes,
Washer sign. Washer sign. Wow. Washer sign and uveitic pigments would be seen where? In relation to the lens. So this is where you need to have, when you do an exam, you do a thorough exam. So there's nothing like a superficial examination with a, with a kind of a pen light. No. Now you need to know where are these deposits, somebody called pigment, somebody calls blood, where is it located? So if you made a thin section of your slit beam, you would realize that we would expect these pigment deposits for washer's ring or broken Seneca anterior to the lens capsule. But if you find these under the capsule, does the diagnosis change? How does it change? So I told that surgeon to go ahead and do a cataract surgery, which he did, okay, and I also asked for doing X-ray of it. And what do we find here? We find foreign body, metallic foreign body. So here is siderosis bulbi. You heard of siderosis bulbi? Because of retained iron foreign bodies. Okay, and this is what you have very classically. These are subepithelial deposit of iron. Okay, and you would have diagnosed them very easily by doing a good clinical exam, right? So that is the significance of a very thorough clinical exam followed by a very targeted. So we want to rule out, is the foreign body visible, not visible? And of course, once it is visible, it's so easy to remove it.
So where was the FD?
Yeah.
The FD was in the posterior segment.
Yeah, it's in the vitreous. There's a electrolytic dissociation of the iron.
And this was the X-ray was done before the phaco was performed.
It should have been removed, the foreign body.
Yeah, we should have removed it. Same.
No, I don't think we would remove, because we need to remove the cataract even for vitreous surgery.
Like a phaco tract.
Yeah, you could combine it, any which way. But here is the patient, who wants to rehabilitate quickly. The cataract surgeon is the one who's sitting on this cataract. He said, go ahead, remove it. We'll do the two-stage procedure. Okay. Personally, I feel more confident doing two-stage procedure, because the cornea gets a little bit of pyramids during cataract surgery. The cataract surgery is not great. Okay. So it sometimes can compromise when you're looking for a very tiny foreign body, you could miss it. Anyway, just beside the point, just to introduce the subject of a good clinical exam. There's no alternative to a good clinical exam. Now, this is an 8-year-old child walks into the clinic. What is so unique about this patient here? This is a slit beam exam. And what are you seeing here in the slit beam? Yeah? Cells in the anterior chamber. Very nice. Very good. So what is so strange about these cells? Very large cells. So when you are seeing, when you are seeing cells in the anterior chamber, what could be the possible reason for those cells? You could see in patients with, say, microhyphema, you might see RBCs, okay? And RBCs would be the smallest cell, and they would appear just like dust particles, okay? Then you would see WBCs, white blood cells, okay, would be a little larger, okay? But if you see such huge cells, your antenna should go up. Why such big cells? Okay, and it turned out that this, when we did the 90-day exam, and this is on 90-day exam, sorry, this is moving. So these are the vitreous infiltrates, okay, and when you see this kind of a patient, you think of infiltrative retinoblastoma, which typically occurs in much later age. They would not have any deposits or tumor-like masses. Okay, so in children, think of that. Okay, you may ask for ultrasonography to pick up the, typically they will not have calcification. Infiltrative retinoblastoma are difficult to diagnose, and here is one reason for doing an AC tap, to look at those cells by cytopathology. Or you may have these deposits here, lung-wide deposits, okay, here in the anterior chamber. Again, think of malignancy. Now, I like to show you a patient. She's 60-year-old woman, and she was symptomatic for 6 months and presenting with 6-18 vision, and the other eye was counting the vision, and we found was that she had aqueous and vitreous cells. Okay, so even yesterday I was talking that when we are looking at old people symptomatic for a long time, having some kind of inflammatory reaction, you need to ask the patient, about what might have happened in the past. And she said that 5 years earlier, she had been operated for periampullary adenocarcinoma, and it had been resected tumor-free. So that was the report. Well, we were wondering, what it might be. So we ordered for an ultrasonography because media was not very clear, and you can see there's a lot of these hyperreflective shadows in the vitreous cavity. 5 years, periampullary adenocarcinoma, which is a highly malignant tumor, resection-free of malignancy, and you have a patient coming back with inflammatory reaction. So we wanted to make sure whether she had that adenocarcinoma, and we went and looked for the histopathology, and the histopathology, sure enough, she did have periampullary carcinoma. How do you put 2 and 2 together? Okay, so we did a vitreous surgery, diagnostic vitreous surgery. We didn't see any malignant cells. Okay, she was treated with steroids, and she didn't respond to steroids. So non-responder to corticosteroid therapy. Okay, now what it might be? So what should we do? Should we do a repeat surgery? Sure enough, because many a times first surgery may not yield the results, and if the condition persists, the inflammation persists, you go again, and that is where we found in the second surgery, we found that she had the malignant cells, the kind of cells which we had seen in the histopathology, exactly the same. So this was periampullary carcinoma, which was metastasizing to the eye 5 years later. Now why should we know about it? Now we know that this patient has a metastatic disease. Okay, we reviewed all her systems, she didn't have anything, and then we found that she had these cellular deposits in the anterior chamber. Since she didn't have any systemic evidence of malignancy at this point of time, it was localized only to the eye, she was treated with external beam radiation therapy. That's what the oncologist thought that we could just treat. She responded very well. But does she get rid of this metastatic? No. She had a recurrence after 6 months. At this point of time, you can see she's presenting as these deposits here on the back of the cornea. Okay. And this is AC media, same eye, the other eye has a cataract. Now again we look for any systemic evidence of metastasis, and sure enough, she had this large deposits in the brain. So when it is metastasizing to the eye, sure enough, look for metastasis in the brain, because that's where commonly you will find. So that is what she was waiting for, palliative therapy, and she died. Okay, so that is where the significance of making confirmed diagnosis from some of these patients who have unusual presentations. Now, I think we have discussed a lot in the last 2 days on these two. So, evaluation of hypopyon in young adults. So I think this question Brian asked yesterday. So what would we name?
27.
HLA B27 and Behçet's. Okay, so you know that these are the two, and keyword here is young adults. Now supposing the patient happens to be a 4-year-old child, how would it change? How does your evaluation change?
Come on, you guys know
GIA.
GIA presenting with a hypopion. Come on. See this very large hypopion in a 4-year-old child, GIA. GIA is why you patient doesn't know. You know, it's accidentally discovered because teacher finds the child cannot read or cannot see the blackboard in the classroom. Okay, it's a good, I've shown you that. But retinoblastoma can present as a hypopion, where, you know, what you have to ask here a question. Is the child eating, playing well, eating well, okay, symptomatic? Because typically in these patients, lymphoblastic leukemia, it's a favorite site for lymphoblastic leukemic cells to be sequestrated. They find, you know, these are the hiding sites, some of these, like the bone marrow, like the testes, like the eye. Okay, these are the niches where these cells will hide because the immune system of the body cannot access these cells. Okay, so that is where the significance. So where you put a needle, do an AC tap, and you have it, the diagnosis right there, and you could save the life. Now, how about evaluating hypopion in old people? Like this guy. He says, you know, he's 70 years. Okay, he says he had some fever, backache, and 1 week, you know, the vision is decreased. Right eye more than the left eye, and you can see he has hypopion in both the eyes. This is the right eye, this is the left eye. Okay. We examined the fundus, no view of the retina. We did an ultrasound for both the eyes, and we found a lot of moderately high echoes, and the retina was attached. And we thought of initially, like we treat all the patients initially with topical steroids and atropine. So that is what, you know, we did. And we thought, what do you think? What are your thoughts here? Fever, backache, you know.
endogenous endo.
Very nice. Endogenous endophthalmitis. So we thought this patient would probably have endogenous endophthalmitis, an old person, you know, had fever. And what do you do for endogenous endophthalmitis? So you order for blood culture and urine culture, and this is what we did. And we found that he was positive for Staph aureus. And since he was positive for Staph aureus, so he was given for whatever is the standard of care for the treatment, antibiotics, but he didn't respond. We did a vitreous surgery. He continued to, you know, since he was not responding to antibiotics, systemic antibiotics, intravitreal antibiotics, we thought we'll do a partial vitreous surgery. So we have nowadays very low threshold for doing vitreous surgery for patients where we are not able to make a firm diagnosis and they are not responding to our conventional treatment. That's what we did. And what did we find? It shows non-Hodgkin's lymphoma. So here is a non-Hodgkin's lymphoma presenting as hypopion in both the eyes, and we have what we call a red herring, a urine and blood culture positive. Now, the guy died, you know, that was the most painful part of it. While we were trying to figure it out, we lost very precious time. You follow? So you have to take prompt action. In unusual situations, you have to take a prompt action. Okay? You can't leave them just like that.
Bro, ask a question. So for a vitreous biopsy, do you usually just do a cord retracting or you do the full TPPP?
Yeah, you could, depending upon how comfortable you are in removing. So the victim is as comfortable as a surgeon is. So if you are an inexperienced surgeon, you would do a core vitreous surgery. If you are an experienced surgeon, you would like to remove as much as possible. Okay? But in this kind of setting, because we don't know what we are dealing with, are we dealing with, really endogenous endophthalmitis, wherein you would like to remove as much as possible, or are we dealing with a primary vitreoretinal lymphoma, where you will remove only a core vitreous biopsy might give you the diagnosis. But since we plan to do a number of tests, okay, I'll come to that in my second lecture, I think an hour later. We'll discuss what all we do with the specimens that we collect, okay? Now we'll go on to the next patient, and this is a patient, it's a big learning outcome in this patient. She was 49 years, she had floaters, and she was symptomatic. You can see in the right eye, the media is because of the vitreous, and there's no CME or no CT, and she has some vascular leak. We don't know what kind of vascular leak it is, but there's a vascular leak. So in this kind of setting, we do the labs, and we did the usual labs, and we find that she has the skin test positive for tuberculosis, and she has some evidence on X-ray chest. She has raised ESR, and of course she didn't have syphilis. So the usual treatment for these patients is a highly positive skin test for TB. Our first thought is that she has intermediate uveitis, which is caused by tuberculosis. So she's put on anti-TB drugs, full course. You heard very elaborate lecture by Dr. Gupta yesterday on how to manage these patients. And sure enough, we also gave her prednisone 60 milligram and topical treatment. She didn't respond to this oral treatment. So we thought we were not giving adequate steroids, and at 4 weeks we gave one posterior injection of triamcinolone. Didn't work. We gave it again after 4 weeks, so she got this kind of treatment. So on, we kept seeing this patient over a period of time, and now it is almost 10 months from the diagnosis, and she has still the same picture. She has vitreitis, which has not responded to steroids, which has not responded to posterior subtenon triamcinolone injections, and the vascular leak is persisting. At this point of time, we thought we'll do a vitreous biopsy. It didn't yield anything. We didn't see anything. Okay. By now, 15 months have gone from the first presentation to us, and the media is cleared now because we have done vitreous surgery. And what we see here is these yellow deposits, and you can see the retinal vessels are coursing over these deposits very nicely. Okay, you have this fluorescent angiogram here, and this is the time when you think very seriously, are we dealing with primary vitreoretinal lymphoma? Okay, so already 15 months when she presented to us. So we thought we'll do OCT. In this kind of a setting, OCT is very, very informative, and what you find is these deposits under the RPEs. If you see this is almost, I would say, pathognomic sign of the primary vitreoretinal lymphoma. So you will have all these slides given to you as a presentation. I'm sure Cindy is collecting all these, so you will have for recalling or for flashing your memories. So we thought at this point of time, we said, no, we must go in again. And what you're seeing here is we are having discussion with her. She's healthy. She says, where do I have the cancer? I'm so good. Okay, why you want to do surgery again and again? And this is what is happening. We are documenting the change over the next about 6 weeks. You can see these lesions, same site, they are regressing, they are coming up. So spontaneous resolution, I think this point was discussed yesterday again, that lymphoma cells are sensitive to corticosteroids when we are treating them. Okay, so when you want to do a biopsy, they should be off steroids for at least 10 days. So you switch off steroids and for at least period of 10 days before you go in and do a vitreous surgery or you do a retinal biopsy. And here what we thought we'll do now, the time has come to do a retinal biopsy, and this is what we did. At that point of time, I thought, let's do a retina, so we don't know whether it wears the, so we do, complete vitreous surgery, we do the diathermy, we move the flap of the retina, about 1 millimeter size, 1.5 millimeters, and then scrape off with a soft cannula, you aspirate the deposits under the retina. And what is the report? Histopathology, nothing. So retina was good. Okay. And then came the report from cytopathology. This is a non-Hodgkin lymphoma, a B-cell lymphoma. And meanwhile, we have been, consulting others and neurology. There is nothing on bone marrow biopsy. Once we know the diagnosis that this is a vitreoretinal lymphoma, the treatment is so easy. Okay, and this is what we gave intravitreal methotrexate to this patient, and you can see the same site. This is the site of the surgery, the biopsy, and these were the lesions, and you can see the response to our intravitreal methotrexate. Okay, and the other eye, even this tiny deposits. Now you can. So what would you do if this kind of a patient came to you? What would you do? OCT, okay? Even this tiny deposit here. And dissipate following methotrexate. So should we stop follow-up? This patient is good forever? No way. No way. So 30 months after first presentation to us, she presented to neurology emergency with seizures. And she had gait disturbance, and she had slurring of speech, she had facial nerve palsy. She had everything, going on. And at that point of time, she had these MRI scans which showed that she has now manifesting in the brain the CNS lymphoma. Of course, she underwent whole brain radiation, and the usual stuff. She didn't receive rituximab. In the present day, she would be treated with systemic rituximab infusion. So this is following treatment. She became all right. So now it is 3 years after she first presented to us. She looks good in both the eyes. The whole brain radiation didn't really make her, less intelligent. A smart woman. 3 years, she's very good. This is 4 years after the initial presentation. She is still, this is the site of the biopsy. She's still very good. 5 years, she's very good. 7 years after the first presentation to us, she had big, huge recurrence in the brain of the CNS lymphoma, and she expired. So significance of this patient, and as a very instructive patient, this case was reported by us in VAMJ case reports. What are the learning points from this case? What have we learned? That primary vitreoretinal lymphoma can present as vitritis, it can present as vasculitis, and we need to have very high index of suspicion for suspecting these cases. Sub-RP deposits would provide a very strong clue, especially in those patients who are not responding to the treatment. And as I said, we don't hesitate to perform repeat surgeries in these patients. First surgery may not yield anything. Now when we go back, and this is important, this is very important, and we did go back and looked at how did we miss for such a long time? Why did we take 1.5 years to diagnose this patient? So what did we find? Even at 3 months, she had these, you can see this, some of these dark lesions here. Okay, hypofluorescent, you can make out? Yeah, you can make out. And at the same time, you can see these hyperfluorescent dots. Okay,
Even on the color photos, you will see that.
you can see on
Yeah.
color photo. Yeah, you can see these. This is at 10 months. Okay, this is the time when we actually started suspecting. Okay, and this, now what is it called? Very few things will cause this leopard skin pattern. So when you start seeing hypofluorescent and hyperfluorescent lesions, dot-like lesions, okay, you think of a leopard skin appearance. Okay,
Can chronic CSCR look a bit like this one?
chronic CSR will not produce this kind of a pattern. This will cause, more like you'll see the fluid dripping down, and there will be tracks, and of course you will have much more localized rather than this. Okay, so you think of, if you have to think of, you think of syphilis. Syphilis will produce exactly, choroidectitis would produce this kind of leopard skin appearance. Okay, so these are the clues in this patient. Okay, for diagnosing a vitreoretinal lymphoma, and we learned vitreal time lessons. Now, yeah, sure.
So when you first diagnosed her with primary vitreoretinal lymphoma, when you did the OCT and everything, right, did we actually scan her brain at that point in time?
Yeah.
Which was
We
normal?
at that time we seriously thought of she has. I showed you that slide. We did the brain MRI, and we did a the entire systemic workup to see if we had any clue. We didn't know at that time that we had a vitreoretinal lymphoma on our hands. We were seriously suspecting that there is some kind of malignant lesions on there.
Right. So my next question relates to the first. I haven't got much experience in dealing with this. What if you've got a patient with exactly as you presented, MRI scan is normal? And
It would be normal.
Presumably hasn't affected the CNS yet.
Yes.
And maybe we do a lumbar puncture, you couldn't see anything at all. Would
Yeah.
you still have to treat this as if it's a CNS lymphoma and to treat
You know,
the CNS?
that's what I told you, that this is a hugely debatable issue. Patients who present with only disease limited to the eye, should they be prophylactically treated with intravenous methotrexate infusion, or the rituximab and intrathecal methotrexate? The neurologists are always hesitant. They want to know whether there is actually a CNS lymphoma. So what they do is do a CSF tab. They will like to do a cytology of the CSF, and if they do not see lymphoma cells, they will not go and treat a brain which is free of malignant cells as yet. But we know that microscopic CNS lymphoma is existing even at that time. It's our inability to diagnose, that prevents, or there is a hesitancy or hesitation to treat very aggressively. So the other alternative is that you treat what you see. So we treat the local disease in the eye and keep a close watch. Okay, and repeat MRI scans frequently. Look out for any signals. You don't leave them alone, like this patient was left alone. And she came after 30 months, a year and a half after we made a diagnosis that she had a CNS disease. Okay, so these patients follow a definite protocol of frequent MRI scans, but you can't do it every day. You can't do it every few weeks. The patient will go crazy. You can imagine the kind of stress this lady went through. Very smiling with her, and she had lease of life for at least 7 years after we made the diagnosis. Now this one is another. Again, she is symptomatic now for 1 year. Okay, and she has, lot of stuff going on, and she had AV malformation in the kidney. She has hepatomegaly. She has calcific deposits in the chest X-ray, and she has reactive cervical lymph node hyperplasia. So she had cervical lymphadenopathy, she had hepatomegaly, she had chest which showed some calcified nodes, and she had TB test positive. So we thought, well, this patient probably in the case of again intermediate uveitis, and she was already when she had received, when this picture was done, anti-TB drug for about 20 days, and she had hand motion vision. Now this is disproportionately low vision for the kind of inflammation she had in both the eyes. We were not sure what we are dealing with, so under the circumstances we did a vitreous surgery. As you can see, the media got cleared. This is the kind of intense peripheral vitreous. You can see how dense it was. And cytology said that this is activated lymphocytes. Okay, so lymphocytes which are activated. And PCR was negative for any viral or TB or the usual infective agents. It was negative. Now here you have a patient who we have done the vitreous surgery, and we find only reactive lymphocytes. Okay. At this point of time, we followed her up for 6 months, and she was doing reasonably well, and she developed a cataract, as is usual. These patients undergo vitreous surgery, they'll develop in due course a cataract. And then she stopped coming to us. Now what we had done was, the vitreous we removed, we had saved that vitreous with the hope that one day our lab would have the kits for doing cytokine analysis. Okay, so when the kit came and we had a number of patients, we had collected and saved the vitreous fluid, saved at -80 degrees Celsius. And when this kit came, I asked for the report. Our lab reported that we have done the cytokines, and I said, just show me a chart. And what I found in the chart was that this lady's vitreous fluid had abnormally high IL-10 levels. See the difference? Actually, when you are evaluating IL-10, IL-6, I think Dr. Vishali discussed this yesterday, if you recall, IL-10, IL-6 ratio. IL-6 is a pro-inflammatory cytokine. IL-10 is an anti-inflammatory cytokine. When IL-10 is overexpressed, that means inflammation is already subsiding, it's responding. So in an eye which is inflamed, and you find IL-10 levels are high, and they are higher than IL-6, okay, it's a very strong indication that what you are dealing with is a lymphoma, and this is not idiopathic inflammation. Now this patient had been lost to us, and a year later, this is 1 year after she was lost to us, and we started looking for around. So we, called basis, and we could finally track this patient. And where did we find her? Yeah? She was admitted in an ICU of a hospital in a neighboring city, and she died of, you can see this is, I obtained the images from her son who was looking after her. He shared these images and was diagnosed as CNS lymphoma. So again, a very learning point here, that if nothing else, and you are doing vitreous biopsy, get that fluid tested for IL-10, IL-6 ratio. Okay, and you would get a clue as to the possibility. Here again we lost this patient. So you see how we learn from patients whom we lose rather than the patients whom we treat successfully. Okay, so learning here is from failure, and this is for lifetime. Okay, because then you would not make this mistake. Now next patient is I want to share with you, and this patient was being treated again somewhere else for more than 6 months with posterior subtenon triamcinolone acetonide, and you can see here what do you think is happening here? Yeah? What is it? Ischemia. Okay, anybody else? Any other thoughts? You think this is choroiditis? No? More retinitis. So, yeah. So what we are seeing here is this retinal vessels coursing over it very nicely. Okay, it's not getting lost there. In retinitis, we expect that, like what I've shown yesterday. We expect the retinal vessels to be obscured as they are coursing through a retinitis lesion. Sure enough, it's close by, but the person who was managing this patient thought of that we are dealing with a patient of choroiditis, and all choroiditis you treat with corticosteroids. So this guy has been receiving posterior subtenon. So what do you see here apart from the fundus picture in the history? What is so unusual?
It's not responding, it's asymptomatic.
Yeah?
It's not
Symptomatic.
It's asymptomatic. It's like
So it's a
treatment.
symptomatic for 6 months, not getting relief, to the usual treatment that is given for uveitis, okay, or choroiditis. What else is unusual? Anybody?
It's counting this, you don't expect this to be counting this.
Okay, you don't expect it to be counted finger. Good. What else? "66 years. So when you are seeing the extremes of ages, to expect a 66-year, we have gone over it, the age, ever since. Old people, old women, I think sarcoid, especially in black old women, sarcoid would be on top of the cards, but otherwise it's not usual to have choroiditis in a 66-year-old person. Now what we did in this patient was, now we did the OCT, I'm not showing you the OCT, and we found again the deposits under the retina, and what we have done here is doing a diagnostic surgery under air so that we get an undiluted vitreous sample, and instead of doing a retinectomy, and removing a piece of retina for pathology, what we have done here is created a small retinotomy and did a cytology. Now what we found was that these cells, because these are cells which are not adherent. Cancer cells, typically they don't adhere to each other, that's how they disseminate. There's nothing binding them or keeping them, So they lose that adherence. Okay, so they could be mobilized. You can push them and get them out through a tiny hole like what we did in this particular patient. And again, the cytology shows large B cell. Again, you do all kind of stainings and PCRs, and you find that fits in with the B cell lymphoma. Now, as I said, once we make a diagnosis, treatment very often is not a challenge. Challenge is in reaching the correct diagnosis. Treatment is not. We know the treatment. Okay, you can get that within 10 seconds from your smartphone. So what we did was give intravitreal methotrexate. This is half the dose given because the vitreous cavity was full of air. So we gave it so much of the confidence, we gave it right on the table. The moment we did the diagnostic surgery and the cytology, we said, no, this is lymphoma, no doubt about it. We had no doubt. Okay, because we could extract those cells. They came running into the cannula, you know. And what do we expect? As I said even yesterday, methotrexate is these cells are very sensitive to methotrexate, and this is what you find within 2 weeks. The pathology has disappeared. This is 4 weeks later. Good. We keep following this patient. Now, till I followed this patient, he had no CNS lymphoma as yet. Okay, so we monitored on MRI brain. Okay, but we know what we know, that by and large 80% of these patients are eventually going to develop CNS lymphoma. That is the association. Okay, it's a very, very close association, that once you see lymphoma in the eye, it's given that the CNS lymphoma would be, and that is how the controversy, that even if you don't see lymphoma in the brain, the patient must receive therapy. So there are very two strong opinions on this issue. Others would say, well, we'll wait till we see any CNS lymphoma, wait and watch. So what are the learning points here? So in this patient, we learned that during diagnostic video surgery, you could easily aspirate these deposits. You must remember, these deposits, they start in the subretinal space, they start infiltrating the retina from there, and then they come into the vitreous. So you could locate at all the 3 sites these lymphoma cells. Okay. And I had also shown you that primary vitreoretinal lymphoma is extremely sensitive to methotrexate, and 80% of them will go on to develop CNS lymphoma. Close follow-up with MRI scan is indicated. Now look at this lady. Now she is 65 years, and now she is presenting. She is symptomatic in the left eye for about a month, and this eye, the right eye, what does she have? Atrophy. With Bonne's PQ pigmentation, like what you see in patients with retinitis pigmentosa. She has undergone cataract surgery in both the eyes 4 years before she came to us. Okay, she has hand motion vision, and then you know this exudative retinal detachment here. She has a lot of hemorrhages in front of the optic disc. Okay, and this is 4 days later. Okay, what do you see here? As she sleeps on her left side, the whole that cellular deposits, they move, you know, on the left side. Okay, you make her upright, it moves down. Okay, so these kind of floating. So this is what I said. They're non-adherent. They're freely kind of moving around. Okay, this patient. Okay, and now what I wanted to show in this patient is this appearance on angiogram. You see these dark spots here, and those dot-like hyperfluorescence. These dark spots are because of the cells are deposited under the RPE, so the RP starts proliferating. So you have some pigment there, and this pigment blocks fluorescence and seen as dark spots. And the area where the cells are lost, RP cells are lost, they would be seen as hyperfluorescent. And there is a breakdown, so the RP barrier is broken, and you will see these kind of hyperfluorescence, intensely hyperfluorescent areas. So once you see this kind of picture, you know, it could occur because of metastatic disease, it could occur because of primary vitreoretinal lymphoma. So you have to think in terms of a malignancy, that I am dealing with a malignant pathology. And as I've shown you repeatedly, again, a large B-cell lymphoma. There you are. And then she had simultaneously large CNS lymphoma. Okay. So this patient was again managed by, the whole brain radiation and chemotherapy, and patient was followed. So what do you think happened to the left eye? The left picture looked almost like what she had in the right eye. Okay? This is what it looked like. And the left eye is now developing similar kind of a picture. And we don't know whether what was the course of disease in the right eye, how did she develop. So what are the basic points to remember here? It could present in one eye, eventually it will become bilateral. Okay? By and large, these patients would first present to us, ophthalmologists. The eye symptoms would antedate in majority before the CNS symptoms. Okay, and you see the delay between. So this is from the National Eye Institute, NHS Bristol, where they have the largest experience in the world of these primary vitreoretinal lymphoma. Okay, and what is the average? Average is 29 months between the eye signs and the CNS lymphoma. So this is more than nearly 2.5 years. Okay. So one argument for not giving the toxic drugs like methotrexate and rituximab, which is fine, is expensive. Okay, 2 years in advance before it becomes symptomatic in the brain. Okay, and then when you are treating something, you need to have an endpoint. Every time we discuss what is the endpoint, how do we know the treatment has been successful? In the eye, when we are treating lymphoma, we see the disappearance of lymphoma or reappearance of lymphoma. Okay, when we are treating in the brain and you have no marker in the brain, as far as imaging goes, the MRI or CSF cytology goes, if when we treated disease, when it was still microscopic, we didn't know how long to treat, what to look for as a endpoint of our treatment. Do we keep treating them all through life? We don't know. So these are some of the issues why there's a debate about treating only the eye or treating both the eye and the brain. Right? Now, average delay is 13 months, and I told you that we first suspected about that time, about 13-15 months, in one of the patients I shown you that that's the time. So, if you think I would wait that long now, no way. If I'm not seeing the response of treatment within a matter of few weeks, maybe 2 weeks, maybe I'll have patients for 3 weeks or 4 weeks, I will go in and do the vitreous surgery for reaching a definitive diagnosis. Because I have learned my lesson that waiting for 15 months, patient not responding, and I am still waiting for some miracle to happen. It's not going to happen. Isn't it? And very often these patients, in our experience, were treated as infectious uveitis also. Okay, there's some kind of infectious uveitis. So, friends, I have given you a bird's eye view of malignancy presenting as uveitis, where you are in a position to save the life. Not only save the life, you also save your license to practice medicine. Because if you miss, lymphoblastic leukemia and keep treating that hypomia in a 4-year-old child, you are going to lose your license. So you have to keep your antennas up for anything which is unusual, anything. If one day you feel that, well, this is beyond me, seek consultations. These are red hot potatoes. The longer you keep in your hand, not doing anything, okay, they'll burn holes in your hands. So don't keep these hot potatoes. Reach a definitive diagnosis within a limited time frame. Now, if you wish to read more details, you can read this paper which came last year from our group, okay, on what are the various characteristics, but by and large I have summed up the patient for you. So we still have, I think, for the coffee break, we have just 11 o'clock, so, but still if you have one or question, we can, yeah, please.
Sorry, Prof. Let's ask a couple of things about the IL-10, your static analysis for IL-10, IL-6. One is, do you have a cutoff in terms of how much the difference is before you consider this as very indicative of lymphoma?
No, I told you that what we are looking is not the cutoff values, we are looking at the ratio. Okay, so if IL-10 should be less than IL-6. So if you are doing IL-6 levels in an eye which is inflamed, okay, IL-10 should be low. IL-10 is a sign of healing. So if in an inflamed eye, I find IL-10 is equal to IL-6, our antennas are up. If it is higher, so it's more than 1:1 ratio in favor of IL-10 is a pointer towards lymphoma.
And are there any other cytokines that have been identified?
Not to my knowledge.
And in those cases where they did the CSF analysis or the blood analysis,
Same would hold true.
Do they check?
I think we recently, I think our group has seen a patient where they did from the CSF, I think I don't have the patient with me right now, but from CSF they did despite neurologists not agreeing, okay, not agreeing that this is a lymphoma, our lab said IL-10 is more than IL-6, so be on the lookout for lymphoma. And those guys got convinced, once we showed that level, and the patient was treated on rituximab and resolved. Because in the brain also, the neurologists are confused in India, or maybe in other TB endemic areas. They think this is a tubercular granuloma in the brain. So it's a TB granuloma there. So that's where they get confused. They can't tell the difference between a TB granuloma, which is inflammatory granuloma, from the CNS lymphoma deposits. Okay. So what will help there also is CSF IL-10 IL-6 ratio.
For the IL-10 IL-6 ratio in the aqueous and the vitreous, do you think there's a difference? Because I'm just wondering if that can be one of the ways of tracking response.
I think if you are hesitant to go into vitreous, I would say that these are freely permeable cytokines, so aqueous tap should be good enough.
And how fast do you see a response in terms of the
24 hours.
So the ratios will drop down within?
No, these are chronic patients. They come to us much later. I have shown you one example of lymphoma. He is symptomatic for just 5 days with a hypopion. Okay, so very highly unusual patient that was, old man. But generally they are several weeks, they have some inflammation. But response to treatment, you can see the next day. When you give intravitreal methotrexate, typically given at 400 micrograms, there is a protocol, how we induct and how we maintain for a year at least. So there's a proper protocol. You can see it in the on your smartphone. But the response is seen within 24 hours.
And last question, Prof. With regards to the intraocular lymphomas, now that we have rituximab, do you have any advice with regards to the use of intravitreal rituximab, since that targets the CD20
No, we
directly?
don't have actually rituximab for treating these has been introduced very recently, but people are talking. I'm sure it will be as effective as methotrexate is, but my own experience is methotrexate, so it may be a little. You give me that much license. I'm a retired guy, so I'm not seeing any more patients. So people, more current with this might be using rituximab. But it's being talked in literature, but there's no series as such reported. So no experience reported.
So I have used that in combination as well. So for cases of neutral lymphoma and ocular lymphoma, whereby and I see that I have to inject frequent because the government said we use it in conjunction with the systemic, and I have the patient come back and see that if I see that they require frequent injection, I actually combine. So it's the same doses at the same time. I inject 100 ml happily of the utensil at the same time at the ventricle. So you use a combination, and that is shown already too. So for some cases, it's just that because you're injecting a total of 200, so you may need to do some basic. In fact, I really do say this happens because the pressure is too high, but that you could use a combination of that.
Yeah, please go ahead.
Sorry, I didn't quite catch your point on the 4-year-old child. I know ALL is the thing you were driving at, but the
At
possibility
4
of GIA, you were saying it's not
GIA
possible.
doesn't cause hypopion.
Oh, okay.
GIA will not cause hypopion. It causes a very, very low grade, insidious onset. Uveitis, which does not even cause redness. It's so low that the first evidence in many of these patients and countries where do not have a very robust screening program. Patients with juvenile arthropathy are typically seen by pediatric rheumatologists. They will go to them with joint swellings. Okay, so they could be polyarticular and quasi-articular. We are interested in quasi-articular disease. Remember, unlike rheumatoid arthritis, this disease does not cause deformities. It's not a deforming arthritis. Okay. Now, there was a little bit of discussion with Gwen about rheumatoid factor. Okay, so rheumatoid factor is indicated here, not in adults. It's indicated here because this is where you have what we call seropositive. So rheumatoid factor, if it is positive, and it's positive in about 15% in our experience of children with idiopathic arthritis, and they have this uveitis, which comes on so insidiously. Okay, unless you have a program, and depending upon the number of joints that are involved in systemic disease, more the joints, more the systemic disease, like what we call Still's disease, the chances of uveitis are much less. So frequency of examination in a quasi-articular would be 3 to 6 months. That means even a child needs to be seen on slit lamp for the presence of cells in the anterior chamber. Even if he doesn't have today, we'll call him again after 3 months, again call him after 3 months, till we start seeing those signs of inflammation. If the patient does not participate in this screening program, which many countries they don't have, okay, typically developing countries don't have these kind of screening programs. So, first time they will be noticed to have uveitis would be when they stop seeing. So how do they stop seeing? By band-shaped retinopathy. They are very classic band-shaped retinopathy. They will have cataract, okay, and they will have hypotony. They will have dense anarchy, and the child is not able to see the blackboard, as I said. Okay, and the teacher says, what's happening to this child? The child doesn't know how much he is expected to see. The parents don't know, because the disease comes on so slowly, okay, that even parents don't know that the behavior of the child is abnormal. Okay, hypopion on the other hand is a very acute. Okay, so male, this JIA is typically seen in girls, female, right? So you'll have typically 4 to 7 years old female who would have JIA associated uveitis or JIA. Now, little older, if you go 8, 10 years, male and uveitis, then we think of actually B27 kind of. So they would have that axial spondyloarthropathies, and they will have acute onset, very sharp onset. In fact, the onset is so sharp, patients will come and tell, I was all right till yesterday 3 o'clock when I started having pain in my eye. They can pinpoint the time of the onset of the disease. Okay, this is called acute onset or very sharp onset. You know, you can know I was all right here and suddenly I had this episode. Okay, so this is recurrent in adults. It's happening in males. HLA-B27 is recurrent. So you have one episode, resolved. So these are limited duration, less than 3 months, it will go away. You treat or you don't treat. Then another episode will come in the other eye. Then they will come back to the same eye. Then it will go back to the contrary. So it moves from one eye to the other. That's a pattern. In JIE, on the other hand, you have both eyes simultaneously affected. It's bilateral. It doesn't jump. It's persistent. The course is chronic. So they need to be on lifelong. I think Cindy is getting restless. Coffee break time.
Yeah, the overtime.
Yeah. Okay, thank you. So we can discuss over tea.
Okay, yeah.